Welcome, everybody. Today's General Internal Medicine Mini Grand Rounds is going to be on thyroid nodules, which is obviously a very common thing that we have to deal with. And Sarah Jonas is joining us from our Upper Arlington clinic to give us a primer on this important topic. Thanks, Sarah.
Yeah, so I'm going to be talking about thyroid nodules today, and I have tried to stick with our initial goals of the Mini Grand Rounds. Our initial goal was for this to be targeted to the primary care internist and to keep our talks between 10 and 15 minutes. So I have two objectives today. One is that you'll walk out of here understanding the epidemiology of thyroid nodules, and the other is to understand the approach to evaluating thyroid nodules. So we should be able to easily cover this in the next 10 or 12 minutes. Before I start, I think I'd be remiss if I didn't mention the importance of knowing how to do a thyroid exam. So if you feel like you need to brush up on your skills, if you Google Stanford 25, they have a wonderful series of videos on how to do specific portions of the physical exam. Their thyroid video is excellent, done by Abraham Verghese. The only thing that I would add to his approach is I tend to try and have a glass of water available for the patient and have them hold a bit of water in their mouth so that when I ask them to swallow it just is easier. It feels like it's a more efficient and valuable exam. I put the picture up there on the right to show you as a reminder, if you put your finger on your chin and slide it down, the first thing you're going to hit is the thyroid cartilage, which is nowhere near the thyroid. So you'll go down about 2 notches from there and you'll hit the isthmus, and that's about where you expect to see the thyroid. So take a look at the video if you feel like you need a review of how to do a good exam. Thyroid nodules are extremely common in the general population. In a iodine-sufficient area of the world, you'll find about 5% of women and 1% of men will have a nodule. And actually, if we do ultrasounds on these folks, anywhere between 20 and 70% will end up having a nodule found, and it's going to be higher if there's iron or iodine deficiency in that area. Again, more common in women than men, and we see more of these in our older patients than our younger patients. When we do find a nodule on exam, when we do an ultrasound, about 20 to 50% have more nodules that we didn't feel when we look at them with ultrasound. So it's something that you'll see fairly commonly. The good news is that about 95% of these are benign lesions, multinodular goiter, Hashimoto's, cysts, follicular, and Hürthle cell adenomas, all benign. So the vast majority of the time you'll be able to reassure your patients that this is not something of grave concern. But about 5% of the time you'll see a malignancy. Fortunately, 90% of the malignant lesions are papillary or follicular, which are fairly easily managed. But we do see, the other 10% is medullary anaplastic primary thyroid lymphoma, not as good a prognosis, a little more difficult to manage. And least common is a metastatic lesion to the thyroid. We do see this, but it's uncommon, typically with breast or renal cell carcinoma. So going back to nodules, who are we going to see them more in? As I said, the women and the elderly. Women specifically who have uterine fibroids tend to have more fibrocystic changes in their breasts and a higher risk for thyroid nodules. In men, obviously, this is going to be a rare occasion where you see somebody with an insulin-like growth factor, but those folks have more nodules as well. We tend to see fewer nodules in people who are on oral contraceptives and folks who are on statins. The statin seems to have an anti-proliferative effect, so we think that's the etiology for less nodules. When you're looking at somebody with nodules, you want to think about your pretest probability, who's more likely to have a malignancy. Men have fewer nodules than women, but when they do have nodules, their risk for it being cancerous is higher. Cancer is higher in the young and the old. So if you're between 30 and 60, there's a pretty low risk for it being malignant, but less than 30 and over 60, higher risk. Obviously, there are some syndromes associated with thyroid cancer, and any history of irradiation, whether it's total body irradiation for bone marrow or a stem cell transplant, or a head and neck radiation in the past, increases your chance of having thyroid cancer. But interestingly, the type of cancer that you get is not a worse. It's basically the same as we see in the general population. So that's good news. If you have a family history, obviously your risk for thyroid cancer is higher. And then if on physical exam you find a hard or a fixed lesion, certainly if you're having any local lymphadenopathy or obstructive symptoms, any vocal cord paralysis, and in particular if the patient notes that the lesion has been growing, then that's concerning for malignancy for sure. So going into this, you're going to do two things regardless of their history. Every patient with a thyroid nodule will need to have a TSH and a thyroid ultrasound. The ultrasound is going to help in two ways. One is it's going to characterize the size of the lesion, which will help us understand how to manage it better. And it'll also clarify the anatomy of the head and neck, or the thyroid and the neck, and may pick up cervical adenopathy as well. Physical exam is great, but it's not very accurate. So when they've looked at studies, one study actually showed that 63% of folks who had an ultrasound were found to have clinically important findings different from the physical exam. About 24% had nodules that had more nodules than were initially detected, and about 20% were small enough that they didn't need anything done. So the ultrasound really does change our approach. The TSH helps us know sort of what the next step should be. So if the thyroid stimulating hormone is low, the next step will be to do a thyroid scintigram or thyroid scan. And I'm going to show you an algorithm in a minute. If the TSH is high, then we have to think about whether or not we need to do a fine needle aspiration. Notably, the higher the TSH, the more likely it is to be malignant, and the more profound advanced the malignancy is. So I decided to take some pictures from up to date and share them with you because I tried to think about what are you actually going to use in practice. So I'm going to skip this slide and come back to it. This is a nice slide from up to date just of the initial evaluation, and all the literature that I looked at sort of had the same approach, so this algorithm is a decent reference for you. So you find a nodule, you check a TSH and an ultrasound. If the TSH is low, you're going to do your radionuclide scan. If it's a functioning nodule, if you see hyperactivity, then you'll check your free T4 and your T3. And then you'll go from there. If it's subclinical, then you just kind of keep an eye on them. Many of them, and I have one more slide with an additional algorithm, but many of them will end up converting over to overt hyperthyroidism, which will need to be treated. If you do a scan because the TSH is low and it's a non-functional nodule, then we want to look at what our ultrasound showed, and that'll help us decide whether or not we need to do a fine needle aspiration or just monitor them. So that is the reason I pulled this slide in here. This is busy, but it will give interest to you if you need to do a thyroid ultrasound on a patient because it describes the ultrasound features that characterize from benign to high suspicion. At the right side, you'll see that the risk of malignancy is noted and then sort of what the plan should be. I wanted to provide you with one other algorithm. This is obviously the one, these two combined are going to be the two that you'll use, if you're working on the fly in EPIC. But I really liked this formatting as well from the American Thyroid Association, and I've got the website there, and then it's in a slide or two as well. It's the same information, I think, just in a more readable format. It makes sense the way my brain works. So you do the TSH and it's normal or high. You go to the ultrasound to determine whether or not you need a fine needle aspiration. If it's a high suspicion lesion, even if it's smaller, as long as it's bigger than 1 centimeter, you're going to do a needle biopsy. If it's real small and benign looking, you won't do anything. And then in the middle, it's just got clear criteria there. As you can see on the bottom, based on the cytology, you'll decide what to do. Again, if it's malignant, obviously you'll go to surgery. If you find a follicular neoplasm or something suspicious for a neoplasm, then there are some recommendations. And the recommendations that you'll see are basically the patient, you have to educate the patient. This is probably where your endocrinologist is going to step in. So I'm going to describe it briefly, but honestly, you're probably not going to be making these decisions. But the recommendation will be either to do, molecular studies to determine whether it's high risk or not, or consider surgery in some situations, or repeat biopsy in 2 or 3 months. If you get a non-diagnostic biopsy back, you just obviously have to repeat the fine needle aspiration until you get cells. It was kind of interesting to me how many articles described this. Apparently there must be some issue with people seeing non-cellular findings and sort of thinking, well, that's benign. That is not benign. Obviously, you just keep biopsying them until you find something. And after a couple biopsies, if you can't get a good specimen from the nodule, then most of the references suggested that you go to a surgical excision, whether it's subtotal or total thyroidectomy. So take-home message that I want to leave you with is that thyroid nodules are common. 95% of them are going to be benign, but 5% are not benign. So you want to think about who your higher risk populations are, and do a thyroid exam probably once a year on your exam. You will always order a TSH and an ultrasound on anybody in whom you find a thyroid nodule. That includes physical exam, but any other study. So if you've done a PET scan or a head and neck study for any other reason and a nodule is found incidentally, that the TSH and ultrasound are what you want to do. If the TSH is high or normal, then you base your management on the size of the lesion and the ultrasound findings. If the TSH is low, you'll do a study to see if it's a functional or non-functional lesion, and that will help you determine whether or not you need to do a biopsy. If the cytology is abnormal, if it's sort of in that middle ground, not benign but not clearly a cancer, the recommendation will probably be for you to either do molecular studies or a fine needle aspiration. Occasionally patients will just rather get the whole lesion out, and that certainly is a reasonable option as well. The 2 references that, that idea of just-in-time learning, if you need something on the fly, the American Thyroid Association has these guidelines that are actually excellent and very easy to find. If you just Google American Thyroid Association, their website has it. You can order them and pay for them, but you can also just look at them online for free. So I found that to be a really good, quick resource. And then obviously up to date is in Epic. So I'm going to leave you with that. I think I stayed within my 10 minutes, and open it up for questions if there are any.
All right, let me unmute everybody. Well, I'll kick things off. A couple of questions. Do you know what it's like to have a thyroid biopsy? Like, what if we're going to send our patients? I think a lot of them are probably going to be anxious to know. Do you have any feedback from your patients about what that experience is like?
Yeah, I have not had terrible feedback from my patients. It's basically needle biopsy in the office. All of our providers are going to do it under ultrasound guidance. So it's far less common to get an inadequate specimen if you're not doing it just with physical exam. Okay.
And then as far as your evaluation, so you'll get a TSH, you'll order an ultrasound, and then are there specific people you refer your patients to in endocrinology for this, or is it a general endocrinology referral?
You can do a general endocrinology referral, and what I'll often do is get the referral, get them into the earliest provider, and then I will send an email to that provider saying, here are the basics. Is there anything else you'd like me to do between now and the time you see the patient? And often they want, the thyroid scan or some other antibody labs done, so you can kind of prep them for that appointment. I have never had anybody tell me, no, I'm not the right person for this job. And I think that's because their receptionists do a good job of vetting.
Vetting them. Okay.
Yeah, because Ing is going to see your osteoporosis patients, but probably not your thyroid.
Right. And if a person had a CAT scan with contrast, how soon after can you get a scan and still have it be valid?
I don't know the answer to that, actually.
Okay.
That's a good question.
And the reason I bring that up is that that's a fair scenario that someone's had iodine, and if they've got an iodine load, then the uptake into the gland won't be accurate.
Right. So, and that may be why you got the study or the TSH and the ultrasound in the first place.
Right. You'll get an incidental finding of a thyroid nodule. The person went to the emergency room, they had a CT, chest, and it picked up something on the thyroid, and then you want to get a workup, you get down to this process of getting a scan, but they've had a CT within. I just didn't know whether it was a month or 2 months or what.
No, I don't know.
Okay.
And that's where the clinical, if it's in any way causing symptoms or it's growing rapidly or it's fixed or it's hard, you're going to do a biopsy. You're not going to wait for a scintigram probably.
Right. Okay. Well, let's open up to other people's questions.
I think it might be in the past 6 to 8 weeks, because I just had a patient recently, and Endocrine had asked whether they had contrast in the past 6 to 8 weeks. So I think it might be in that time frame.
Awesome, thanks.
So you said 6 to 8 weeks?
Yeah, at least that's when they wanted to know if it was within that time frame that they had any IV contrast.
Okay, great, thank you.
Any other questions? That one algorithm that you had from Up to Date, it's a little hard to read. It's pretty small, but it's getting at the details of the ultrasound that tells you, right? That one table that you have, the ultrasound findings.
Click on here so I can pull it up. Yeah, so this is the one that you'll use more often, just to kind of lead you through it, and then the question of meet sonographic criteria for FNA is answered on this screen. Okay. Yeah, so if it's a high suspicion lesion, if it's bigger than a centimeter, you're going to do it. If it's a low moderate, but if it's greater than 1.5 or 2 centimeters, you're going to biopsy it as well. Really, the only time you're not going to biopsy it is if it's less than a centimeter or if they say it looks completely benign.
Okay, so that's where the internist is really making. You're making a decision about referral or not referral at this point.
Right.
Okay.
Yeah.
So that's an important one to.
Yeah. So I think when we're looking at this algorithm, honestly, we can manage all of this stuff right down to the, fine needle aspiration. So if you get all that legwork done, then you can call Endocrine and say, hey, this person needs a biopsy. How quickly can you get it done? Got everything done. I think they'll probably be willing to get them in fairly quickly.
Can you blow that up, that other slide?
That one?
If you hit the escape button,
yeah,
I think you can, and hold the control key down.
Yeah.
Blow that up a little bit. So it's size of the nodule?
Yeah, size. So the far right column is characteristics. That's the size. And then the ultrasound features, there are certain characteristics that make it more concerning.
I see.
So that's where radiology is going to be calling high risk versus low. But yeah, the size is, the cutoffs are, less than a centimeter, there's nothing to do. 1 is high risk, you're going to want to biopsy it. 1.5, intermediate, 2, low, and then if it's benign, nothing.
Okay. Well, that's a really good table to reference.
Yeah, that's why I use it. I hate referencing up to date, but I feel like it's worth doing because we all have it at our fingertips.
Right.
And this was the summary that everything else showed, so.
Yeah.
I do like this other algorithm better. I think it's visually cleaner, but it doesn't include the level of detail that this one does.
Mm-hmm. And is screening for thyroid cancer part of our preventive guidelines?
No, it is not recommended.
Are we recommended to do physical exams and try to identify thyroid nodules on all of our patients yearly?
That is a great question, and I searched and could find nothing that gave any standard recommendation on how often a thyroid exam should be done, but it was clearly assumed in every article that people are doing thyroid exams, which I don't think people probably are, but my assumption would be once a year you should examine the thyroid based on this, but that would be probably weak evidence because it has not been studied.
And 64% of the time,
95.
The ultrasound shows something different than what you felt. And am I to interpret that to say, if I felt a thyroid nodule, I go to get an ultrasound, a fair amount of those, there is no nodule there?
Some of them have no nodule. Some of them are less than a centimeter, but just as many there's more than one nodule found. Mm-hmm. Yeah. So, but there is no recommendation for routine screening, ultrasound, physical exam, or otherwise.
Okay. Yeah, I would say more of these come to me incidental findings.
Absolutely.
From a CT scan.
Yeah.
Head, neck, chest imaging of some form.
Absolutely.
That sends these to us.
Yeah.
All right. Anybody else with any other questions before we break? Okay. Well, I'm sure Sarah's available after the talk. If anybody has any questions, we'll post these slides up on our faculty development webpage, hopefully here within a week, and we'll send a survey out to you a little bit later to get your feedback. Thank you.